There are two papers on Better Together in public board papers today. The first is the assurance report providing an update on programme progress, and the second is the consultation plan that would be enacted should there be a board decision to move to consultation at some future point. We will present and talk through both papers before opening up for questions and comments. In presenting these papers, I'll be supported by Claire Madsen, Elaine Norton, Adrian Osborne and Lucy Cornish. So dealing with the first of those papers, I'm going to run through a summarised set of slides. So slide 1. So today's presentation provides an update on Better Together Phase 1, focused on adult, physical, mental health community services. The purpose today is to provide assurance on progress, the evidence informing the work and the steps being taken towards presentation of the pre-consultation business case in September. It is important to say at the outset that this is not a decision-making session. No decisions have been made about the future shape of services. The purpose is to show how engagement, evidence, modelling, clinical advice, pathway testing and assurance has been used to develop and assess potential future models of care. The presentation has 3 messages. First, why the current model needs to change. Second, how evidence and engagements have shaped the emerging future model. And third, the assurance and next steps towards pre-consultation business case consideration and consultation. Next slide, please. Better Together is our commitment to work with communities, staff, partners and the public to transform healthcare services for people in Powys. The core issue is that we must change how we work if we are to continue providing safe, high quality and sustainable services into the future. We are starting with adult, physical and mental health community services because these are the services that most directly affect people's ability to remain independent, avoid unnecessary admission, recover well and receive joined-up support. This includes community hospital and mental health inpatient services, urgent care, mental health access and community teams, district nursing, home first, falls prevention, therapies, diagnostic and other services that support people at home or closer to home. The work is grounded in the shared health and care strategy for Powys, developed with Powys County Council, PAVO and the people of Powys, and now has been extended to 2028 through the Regional Partnership Board. The most important point is that this is not simply a service review. It is about designing services around future need, more prevention, more care closer to home, stronger primary and community care, and better integration between physical health, mental health, social care, and the third sector. Next slide, please. The slide shows the journey from early engagement through to the current technical phase. Better Together began in 2024, and since then the programme has been listening, engaging, and undertaking the detailed work required to develop robust options. Stage 1 pre-engagement helped us understand the wider context and the challenges people see. Stage 2 engagement then explored scenarios for adult physical mental health community services and helped shape the criteria that would be used to assess options. Since summer 2025, the programme has been in a technical phase, testing evidence, developing options, undertaking modelling and building assurance around whether options are viable and deliverable. There have been delays as additional options were introduced through internal check and challenge, but this has only strengthened the process by ensuring a broader and more robust appraisal. We are now moving towards finalising options that could be brought through into the pre-consultation business case for board consideration in September 2026, ahead of consultation if board agrees. The next slide brings together the main elements of the case for change: people, place and resources. Powys is ageing. The population aged 65 and over is projected to increase, while the proportion of people of working age is reducing. This means more people are likely to need care and support, while the workforce available to provide that care becomes constrained. Nearly half of the people aged 75 and over are living with 2 or more long-term conditions, and the number of people aged 80 and over has significantly increased over the last 20 years. These demographic pressures are not temporary, they are structural. The place element is also critical. The map illustrates the scale of rurality and sparse population, with each yellow dot representing an area of Wales that no one lives in. The average population density in Powys is around 26 people per square kilometre, compared to 2,620 per square kilometre in Cardiff. This has a real impact for service design. We do not have the population critical mass to deliver every service safely or sustainably in every location. Some specialist services require a scale of staff, expertise and activity that cannot be replicated across a rural county. Long distances from large population centres also makes recruitment and retention more difficult. The resources element is equally important. Powys has a different financial profile from other health boards, with a high proportion of our expenditure on services purchased from other organisations. The implication is that strengthening prevention, community services and local models is central to quality and sustainability. For the board, the key message is that future services must be designed around prevention, independence and coordinated community support, not simply more reactive or hospital-based care. The next slide brings together the key elements from stage 2 engagement. The central message is that people are not simply opposed to change. They want change to be purposeful, evidence-based and grounded in what matters locally. People told us they want stronger primary and community care, an integrated approach, prevention and early intervention, compassionate end-of-life care delivered by skilled staff, and strong partnership between health, social care and the third sector. They also recognise that some services may be organised differently, including through centres of excellence or regional rural centres, and that some specialist services may need to be delivered outside of Powys where that achieves the best outcomes. But they were also clear that services must remain equitable and rurality, transport, digital inclusion and access must all be considered in the plans. A key point from the local voices slide is the published papers, is that there is a strong civic pride in local services, including the contribution of communities, volunteers and unpaid carers. People also raise concerns about equity of access, travel to district general hospitals, cross-border care, communication and information following the patient, loneliness and isolation. Therefore, the emerging model has to do 2 things at once. Protect what people value about local care while creating a more integrated, preventative and sustainable model in the future. I'm now going to hand over to Claire. Thank you.
Thank you, Deb. Thank you, Deb. So my name's Claire Madsen. I'm the Executive Director of Allied Health Professionals, Healthcare Scientists and Digital. And this slide is particularly important, bearing in mind Katie's comments, because it demonstrates how the case for change is about quality and outcome for our population, not just capacity and finance. And the evidence on deconditioning and delirium shows that prolonged hospital stays can cause real harm to people, particularly for older people and people living with frailty. Slide highlights that up to 50% of older people may become incontinent, for instance, within 24 hours of admission. 50% experience functional decline, and between admission and discharge, 61% of old people develop a new disability and are not back to their usual level of function after 1 year. So the implication from this slide is clear. Hospital care remains essential for our population. However, it should be focused on people who actually need hospital care, and it should be time limited. They should be just there for the right length of time. where it is safe and appropriate, helping people remain active, independent and supported at home in their own community can improve outcomes significantly. Next slide, please. So the national evidence tells us that unnecessary or prolonged hospital care can cause harm, but we also have data from PAWIS that shows why this is important as well. We continue to see high levels of hospital activity, long lengths of stay and increasing demand from people living with frailty, dementia, multiple long-term conditions and complex physical and mental health needs. The slide shows over 37,000 out-of-county admissions, generating almost 100,000 bed days in 24-25, and the average community hospital stay is around 40 days, which is almost double the Welsh expectations, which say we should expect around 21 days. It also shows that almost half of the people in our community hospital beds are clinically ready to go home, demonstrating the need for stronger community alternatives and discharge support. The fuller presentation in your papers also shows that includes patient pathway testing, a rapid review of community hospital inpatients, and a week of care review of emergency admissions. That testing showed that a significant proportion of hospital activity could potentially be prevented, shortened or managed differently through a stronger community-based model. But the key point from this slide is that the case for change is not based on one source of evidence. It's supported by national evidence, local data, pathway reviews and engagement. Together they point towards stronger prevention, earlier intervention, integrated physical and mental health support, more care at home and better rehabilitation and recovery in the community. Next slide, please. So this slide is also important to emphasise that the future model is not starting from scratch. There are already important building blocks in place across PAWIS. These include access developments such as our single point of access, our 111+2 service in our mental health services, and our digital services. Prevention work around frailty, early intervention, and community support, and alternatives to admissions such as our virtual wards and crisis response. We have recovery and independence services such as reablement, intermediate care, and discharge support. And we have increasing integration between physical, mental health, social care, and we work closely with our third sector organisations within PAWIS. Better Together brings these developments together into a more coherent model. The aim is to move away from fragmented or isolated schemes and move towards a system-wide approach that can be consistently understood, resourced and delivered. So the message for Bwrdd is one of both confidence and realism. There is already progress to build from, but the evidence tells us that incremental improvement alone will not be sufficient to meet our future needs. I'm handing over to my colleague Elaine now.
Thank you, Claire. So this slide shows the structured route that we've taken from case for change to consultation. We started by identifying challenges and opportunities through the case for change, supported by technical chapters on community services, primary care, mental health and diagnostics. And we then moved into ideas generation through engagement with citizens, staff, communities and stakeholders. Those ideas then needed to be translated into options. Hurdle criteria were used to test whether ideas were feasible enough to proceed. Assessment criteria based on the duty of quality domains, safe, timely, effective, efficient, equitable and person-centred, were then used to test those shortlisted options. These criteria were informed by user and staff feedback during stage 2 engagement, so they reflect what people told us matters. The fuller deck also sets out the assurance underpinning this work, including staff and user insight, benchmarking, independent clinical advice, demand and capacity modelling, strategic assessment, and partnership working. It also referenced learning from other service change programmes, independent advice and assurance, independent consultation insight, CLICE, and staff side participation and external review. The key assurance message is that options are not being developed through preference or opinion. They're being tested through a structured, evidence-based, engagement-led and independently challenged process. Next slide, please. This slide brings together the emerging future model across mental health, physical health and urgent care. The important message is that these should not be seen as separate models, but as parts of one integrated physical and mental health community system. The mental health model is described as an integrated recovery-focused system, an early intervention and no wrong door access. It spans prevention, crisis, inpatient care and recovery, with a strong emphasis on community-based support, crisis alternatives and integration with physical health. The physical health community model focuses on proactive prevention, rapid, time-limited intermediate care, multidisciplinary place-based teams, urgent community response, rehabilitation and hospital at home services. It's designed to improve independence, reduce avoidable admissions and enable safe discharge. The physical health inpatient model is not about saying beds aren't needed. It clarifies the role of inpatient care within a wider system, a step up, step down, rehabilitation, complex care, mental health inpatient support and end of life care where that's required. The urgent care and diagnostic model strengthens timely access to assessment, diagnostics and treatment for non-life-threatening conditions, aiming to reduce avoidable emergency department attendance and unnecessary travel out of county where that is safe and appropriate. So the overall shift here is from fragmented pathways to one coordinated approach. Earlier prevention, simpler access, faster community response, inpatient care focused where it adds most value, and stronger recovery and independence. Next slide, please. So behind all the modelling, analysis and option development are real people like Gilydd. So Gilydd is 75. She lives independently on a farm in Powys. Welsh is her first language. She's got vascular dementia and experiences delirium during a UTI, raising both physical health and mental health support needs. Today, Gilydd's pathway risks becoming fragmented. Physical and cognitive decline may be recognised late. An acute episode may be managed outside of Powys. Her family may carry the coordination burden, and inpatient care may be considered separately from wider support at home and in the community. The future model is designed to feel different. Instead of multiple services and multiple plans, Gilydd would have one coordinated team around her, bringing together physical health, mental health, independence and well-being needs into a single pathway. This means more support to stay safe at home, earlier intervention when her needs change, integrated monitoring and step-up care, and specialist inpatient care when that's required. The slide also highlights better continuity and support for individual needs. This is the practical meaning of the future model: less fragmentation, fewer handoffs, more support at home, and one joined up team working together to help people stay independent, well, and connected to their community for as long as possible. The message from this slide is important. Better Together is not simply about changing services. It's about changing the experience of care for people and families, from navigating separate pathways to being supported through one person, one plan, and one pathway. Thank you. I'm going to hand back to you now, Deb.
Thank you. So next slide, please. So no decisions will be made until there has been full and meaningful consultation with the public and staff about the future of community services in Powys. The consultation is expected to ask important questions about how we ensure a greater focus on preventing ill health, how we strengthen primary and community services so that more people are supported to stay well in Powys, and what the right future model is for bed-based services. A pre-consultation business case is currently in development and will be brought to board in September for a decision on whether to proceed to consultation. If board agrees, consultation will then provide the opportunity for formal public and staff feedback before any future decision is made. The key dates are: board papers are published in the week beginning the 7th of September. Board decision on launch of consultation is on the 16th of September. Public consultation will run from the 21st of September to the 13th of December, and then we enter a period of conscientious consideration of all of the feedback in Q4 of 26-27. A post-consultation business case will be considered by the board in spring 2027. In closing, the evidence, engagement and assurance work to date all points towards the same direction. Future health and care needs in Powys are most likely to be met through a stronger focus on prevention, integration, recovery, community-based support and care closer to home, whilst ensuring that inpatient and urgent care services are available when needed. As a reminder, the board has not been asked to make any service change decisions today. The board is being asked to take assurance that the work has progressed through a structured, evidence-based and engagement-led process, and to note the route towards pre-consultation business case consideration in September.